Good morning. We're going to talk about comprehensive review of Tommy John reconstructive surgery, as well as talk about improved rehabilitation strategies and new treatment techniques. Little introduction here. UCL injuries have become very prevalent, especially recently in the last couple of years. Most notably here with Brian Wilson, a local Major League pitcher for the Giants, just had Tommy John surgery about a month ago. And it has been noted that 1 in every 9 MLB pitchers has had UCL reconstructive surgery. This is very significant because there's about 350 pitchers in the major leagues, and 1 in every 9 of them have had that. And that was actually back in 2003, so the numbers have probably increased since then. And because of the increase in injuries, there's been an increase in Tommy John surgeries as well. Dr. James Andrews down in Alabama has gone from performing less than 10 Tommy John surgeries about 10 years ago to over 75 surgeries per year, and this was noted back in 2010. A little background information here on Tommy John surgery. Tommy John was a professional baseball pitcher from 1963 to 1989 and was pitching with the Dodgers when he felt a pop during a game. Was looked at by Dr. Frank Jobe there in the top picture, and they talked about it and determined that he had torn his ulnar collateral ligament. And Tommy John simply looked at Doc and said, "Well, get me a new one." And Dr. Frank Jobe did. And so in 1974, the new innovative procedure was created, and Tommy John had a new UCL ligament. And he actually had a very successful outcome. He was out for a year and a half, but that very next year he was named the Comeback Player of the Year, posting a 500 win and loss record. And many other people have had successful outcomes after Tommy John surgery, most notably Stephen Strasburg there in the bottom right. He is one of the top pitchers in the league right now. And if you can look real close on his elbow, you can see the scar from his surgery. And in his most recent start, he struck out 10 guys, but he's still under a strict pitching and inning count. He can't go beyond a certain number of limits, even after a year and a half. So that just, again, stresses the importance of the surgery and progressing not too fast, not too soon. So getting into the anatomy here, the medial elbow consists of the humerus and the ulna bones, and the UCL ligament actually has 3 bundles to it: the anterior bundle, posterior bundle, and the transverse ligament seen in the picture there. But the primary stabilizer to valgus stress is the anterior bundle, and based on its orientation right there. Some of the functional anatomy is seen in the bottom left picture here is provided by flexor pronator group, muscle group, and they provide valgus stability through varus contraction. When they contract, they actually provide that varus moment, even during a throwing motion where valgus stress is present, and that helps to dynamically support the joint and resist that valgus load. Flexor carpi ulnaris and the flexor digitorum superficialis are the 2 main muscles noted on EMG studies as the most active during these phases of throwing to be the primary dynamic stabilizers. Getting into the general thrower's elbow, baseball is not the only sport that experiences UCL injuries. Overhead athletes in all sports are susceptible to significant elbow injuries. The most common significant injury is a UCL tear. Baseball, volleyball, and football players, as well as javelin throwers, experience stresses to the elbow and UCL injuries. And this is just based on the nature of their sport and the overhead motion with the cocking and the unloading and acceleration phases. You experience maximum external rotation into a violent arm acceleration and a whipping kind of motion into elbow extension. And this creates a repetitive valgus stress, which causes damage and injury. And breaking down the phase of the throwing motion here, this specifically the baseball throwing motion, most UCL injuries occur during the cocking and acceleration phases, as seen here by the circles. With foot contact and the load of the arm, he's going into maximum external rotation, and then as the arm accelerates forward, that load-unload from the cocking phase to the acceleration phase is where most injuries occur based on that violent nature. The actual UCL injury mechanism of injury is repetitive valgus stress, as described previously. And throwing and overuse can produce sharp pain, and this is more of a chronic injury. Develops over time, either small tears or partial tears of the ligament or surrounding structures of the bone and stuff, and can result in a breakdown of the ligament and requires surgery. More of an acute, violent nature of the injury is when a audible pop is heard or felt, and that's with the violent rupture of that ligament, and it's usually during one specific throw, and that obviously also results in surgery. Upon examination, though, the clinician or athletic trainer present should obtain a full history of the injury and previous injuries to the elbow or any other conditions present, as well as evaluate the full range of motion of the surrounding structures. And even before the range of motion, test for fracture, signs of fracture or dislocation, or any other compromise of the joint or structures that are more emergent in nature and require immediate referral to a physician or a hospital. Getting back into the range of motion of the elbow, what range of motion is available, what is painful, what is not. Testing the strength around the elbow, all the muscles that cross the elbow joint or act attached to the elbow joint. And then lastly, getting into special tests and testing the actual stability of the ligaments and structures of the elbow. And this is done most commonly by the valgus stress test, which can be done in full extension, although this is where the elbow is in a closed pack position and the bones are providing support. But you could still feel some laxity of the ligaments. But most commonly it's done in a 30-degree elbow flexed position where the bones are unlocked, and the elbow can be fully tested for stability. But more recent studies have shown that 90 degrees of elbow flexion provides a really good test and outcomes for this. And the milking maneuver, as seen in the picture here, best isolates that anterior bundle of the UCL through that 90 degrees of elbow flexion and dialing them out into external rotation, putting stress on that medial ligament. And the tester can palpate the ligament, as seen in the picture, feel for laxity as well as clicking or popping, and then obviously pain by the athlete as well. So, helping to identify more personally with these injuries, I've presented 3 case studies, all baseball players that I've worked with in this past year. And they're all left-handed pitchers at first, but player A was actually a left-handed outfielder, playing both pitcher and outfielder at the time, and felt and heard a pop in February of 2011. It was determined that he had a partial tear of his UCL, and he proceeded with non-surgical treatment and a PRP injection. And we'll get into that a little later. Players B and C were both seniors, used a lot during their collegiate careers, both left-handed pitchers. Player B felt and heard a pop in May of 2011, and it was determined that he had a complete tear of the UCL. Player C, on the other hand, felt sharp pain and was more of a chronic mechanism of injury, like we mentioned previously, and didn't have that one specific moment where he felt a pop, but over time felt sharp pain in the elbow. And it was determined that they both had complete tears of the UCL, and they both required Tommy John surgery, which we'll get into now. Tommy John surgery, the main technique that was used first by Dr. Frank Jobe in 1974 is the figure of 8 technique. This is where a tendon is grafted from the arm, usually the palmaris longus tendon, which is not needed or even absent, like myself. I don't have one in my forearm. But if it is present, it can be used and pulled out and weaved through the bones, the holes drilled into the ulna and the medial epicondyle in a figure of 8 fashion and tied down to itself. This provides that support medially and acts as a ligament now, the new ligament. Within the last 10 or 15 years, a docking procedure has become more common and actually has had improved results over the figure 8 technique. And this new procedure kind of involves smaller holes on the medial epicondyle as well as sutures at the end of the graft. And the same tendon can be used and passed through the holes of the ulna and then actually docked inside of the epicondyle of the humerus. And then the sutures exit through those smaller holes on the top and are tied down on the bony tunnel. This again has improved results and is more commonly used nowadays. Non-surgical techniques for partial tears or those not requiring surgery. Main idea behind this is rest and rehab and a throwing program and a gradual return to play. This usually takes roughly 4 to 5 months or so still a good amount of time, and but it's a gradual increase back into the demands of the sport and return to play. As well as PRP injection can be used during these non-surgical treatments. And platelet-rich plasma is taking your blood, spinning and centrifuging it, and pulling out the plasma and the platelets that are inside there that have many growth hormones that can increase the healing process. Professional athletes have been using them for a while now and have had successful outcomes, but more studies need to be done on the protocol, the exact protocol and the efficacy of using them based on anti-doping and drug agencies. Whether you get surgery or not, you go into the rehabilitation here, and immobilization is used by a range of motion brace there in the top picture. Therapeutic modalities can be used: ultrasound, electric stimulation, and ice to help with stimulate the cells and healing process, as well as pain control. Then you actually get into the exercises, progressive resistance exercises, using light dumbbells, cables, and therabands, and even manual resistance techniques. Then the last stage is the throwing program and the return to play guidelines, which we mentioned previously. And this interval throwing program is set distances and set amounts of throws, set volume, and progresses accordingly through the whole end of the throwing program. And once they're completed that, you don't want to just throw them back into 100% participation. You want to gradually return them to play, and the guidelines for that is slowly integrating them back into practice, maybe not a full practice for the first couple days or weeks, and then gradually getting them back into 100% activity. My personal preferences for rehab are PNF techniques, proprioceptive neuromuscular facilitation. Combined movement, it involves combined movements of the shoulder, elbow, and wrist, commonly referred to as diagonal 1 or diagonal 2, where you get adduction and abduction of the shoulder, external and internal rotation, and then flexion and extension of all those joints. Also, I love to use manual resistance techniques, and this is, in my opinion, and studies have actually shown improvement with outcomes, because you don't use machines or dumbbells and send them off on their own. You actually are with them providing that resistance. Now, obviously, it's more time involving and not always the best to use when things are busy in the training room, but you can use these manual resistance techniques, accommodate the resistance throughout the range of motion, and really target good strength and endurance gains by using these manual techniques. I also really like to target the flexor pronator group. As mentioned previously, these are the main dynamic stabilizers of the throwing motion, and working these muscles improve dynamic valgus stability. The actual phases of rehab are broken down into 4 phases here. Immediate post-op phase, weeks 0 to 4. Main goal here is range of motion. You're working passive range of motion of the elbow. You're working the scar mobilization of the injury site and the incisions. And you can even start working the active range of motion of the shoulder, but the elbow is still immobilized. Week 4 to week 8, you start to get out of the brace, and you still work phases 1 goals. You begin elbow strengthening, scapula and shoulder strengthening, as well as PNF and proprioceptive exercises with the PREs and the light dumbbell work. Phase 3 builds on top of phase 1 and 2, advanced strength phase from week 8 to week 13. You're working strength and endurance and incorporating back into sport activities. This is where you can incorporate throwers 10 and plyometrics, as well as medicine ball tosses. Phase 4 is a return to activity phase from week 13 to week 20, and you can begin a throwing program and a gradual return to play. The main question here is, why is rehab so long, and what new techniques are available to improve recovery time? So these case studies that we revisited here, now that they have gone through their surgery, all of them, as you can see, are out of their brace at week 4. Began the throwing program for players A and B. Player C did not complete the throwing program, is not playing baseball anymore, and is working at a PT clinic. Player B was drafted by the Giants and is actually in an extended rehab and throwing program. And player C was playing outfield, but is converting back to pitching over the summer and making a full recovery. some of the prevention techniques here